Good morning. You are welcome to the health part. I'd like us to talk about hypertensive disorders in pregnancy. With pregnancy, we have different types of hypertensive disorders. The hypertensive disorders in pregnancy, we have first and foremost gestational hypertension, also known as pregnancy-induced hypertension. Then we also have chronic hypertension. Then we have the chronic hypertension with superimposed preeclampsia. We have preeclampsia and then we have eclampsia. So these are the hypertensive disorders in pregnancy that we have. Let me take it again. We have the pregnancy-induced hypertension, which is one, also known as gestational hypertension. Then we also have preeclampsia, we have eclampsia, we have chronic hypertension. Then the last one is chronic hypertension with superimposed preeclampsia. Now let me take it one at a time. With the pregnancy-induced hypertension, mostly it's related to pregnant women who are not hypertensive, but by virtue of pregnancy, during the formation of the placenta, there are certain physiologies that actually takes place. After placenta formation, that is from the 12th week onwards, the placenta is, the abnormalities are supposed to revert or to go back to its former state. Now, in a situation whereby this physiology is not able to reverse, then it leads to what we call vasoconstriction and then vasospasms. When this happens, it puts a lot of pressure on the heart because the heart ideally, when it pumps blood is supposed to pass through these blood vessels without stress. But because there is constriction in the blood vessels, meaning that it's going to put pressure on the heart to work at a rate at which it will be able to compensate for that, so that blood flow can be sent to the vital organs as well as the unborn fetus in utero. And that is mostly seen from the 20th week of pregnancy. That is how come when you check the blood pressure is mostly high from the 20th week onwards. And one thing about PIH too is when the blood pressure is high and you check for urine proteins are mostly negative. So take note, sometimes we do a lot of misdiagnosis where we confuse pregnancy-induced hypertension with preeclampsia, which is not. Cases of PIH mostly do not have remarkable protein in urine, unlike preeclampsia, which goes with protein in urine and then high blood pressure and other factors such as blurred vision, epigastric pain, and other signs and then symptoms. All right. So now let's move on to preeclampsia. With preeclampsia, as I mentioned earlier, with this, there is remarkable increase in blood pressure, that is 140/90 millimeters of mercury or more. And then when you do the urine check, it is noted that there is a urine protein of more than 1 plus. With this, we can say that the client has developed preeclampsia. And eclampsia is the advanced stage where the client goes into what we call fits or seizures. Then chronic hypertension. Obviously, if you are chronic hypertensive, does not mean that you shouldn't think of getting pregnant. So when you are chronic hypertensive, there's a high tendency that you may develop what we call superimposed preeclampsia. But with this, the superimposed preeclampsia mostly happens before the 20th week. That is early stages of pregnancy. That is how you're able to diagnose that this patient actually is having already a chronic patient, but due to the pregnancy or the placenta has developed preeclampsia. Okay, so this is that is how we are able to diagnose it. And then one thing too is these kind of things, when you're a pregnant woman, bear in mind that most of the time, especially with the PIH, the cure is delivery of the placenta. Yes, the cure is the delivery of the placenta. In a situation whereby the BP2 is not able to be controlled, that is where the doctors will advise that we do away with the pregnancy. Doing away with the pregnancy doesn't mean we are going to abort the baby, no, but the baby may not be able to get to term. So mostly such babies are born preterm. And also some of the complications are that the mother may, because of there is constriction of the blood vessels, there may be what we call placental insufficiency. Why placental insufficiency? Bear in mind that it's the placenta in utero that helps to transport oxygen, nutrients to the fetus in utero. Now, there is vasoconstriction, and then that means the blood flow will be minimal, meaning that oxygen carrying nutrients will be low, oxygen binding capacity will be low. Therefore, can lead to poor amounts of oxygen and poor amounts of nutrients to the fetus in the uterus, leading to what we call the placental insufficiency. Definitely, if there's low amount of oxygen to this fetus in utero, that means this baby is at risk of hypoxia, which is high amounts of carbon dioxide in utero and less amount of oxygen in utero, which is not good for the baby. Also, it can also lead to intrauterine growth restriction due to low binding capacity of low transfer of nutrients to this fetus in utero. This baby will be able to grow well. Yes, so this baby will be, I'll say, malnourished in utero. So obviously it can lead to low, and that is intrauterine growth restriction. Aside that too, it can lead to intrauterine demise or IUFDs. That's intrauterine fetal demise or fetal deaths. So these are some of the complications. Let's try as much as possible to visit any nearest health facility as soon as you are able to, or as soon as you get to know you are pregnant. Don't wait. That tradition of waiting for so many months before you see your midwife should be stopped, because these things mostly occurs during the early stages of pregnancy, and if you don't visit the hospital early or on time, these abnormalities may not be able to be detected early. All right. Thank you very much, and thanks so much for listening. If you have any questions, type it under the comment section. Have a nice day. Bye.